Well, welcome to this Pharmacology drug class review on the anticoagulants, specifically the direct thrombin inhibitors. In this session, I'm going to explain why drugs like Dabigatran, a subclass of the DOACs, matter. Furthermore, I will separate this DOAC from other parenteral options used differently in clinical practice. All right, guys, I'm Dr. Busti, and thanks for joining me on This Is Why, a show dedicated to helping healthcare professionals understand the why behind pharmacology and even the drugs that we use every day. When you understand the why, the how becomes easier because that mechanism starts to predict the therapeutic effects. Don't need to memorize it. It also helps us understand side effects, contraindications, monitoring parameters, and even the counseling points. Now, this drug class has some unique features that can easily create confusion, especially on an exam. One is centered around the mechanism of action, and another is around the indications and uses. Okay, guys, as you guys know, as with all of the drug class reviews, we cover some core content. That includes things like, what are the drugs in this drug class in general? Number two, what are the common uses and indications? Not every scenario possible, but the most common high-yield uses and indications. Now, we also then try to summarize what is the main net benefit? Why do you need to be thinking about this drug class and picking it over maybe another drug class in particular for a clinical scenario? Then we're going to dive deeper into the pharmacology, mechanisms, some basic pharmacokinetics, dynamic stuff, right? And then we're going to transition over clinical application, things that you need to keep in the back of your mind, and then we'll wrap things up. Okay, so the first things first, let's cover those agents, okay? So you can see I try to break down agents in those that we use in the acute care environment versus the chronic care environment, okay? Argatroban, most of these in the acute care environment are parenterally administered. That means they're given outside of the oral pharyngeal route, right? We're not going to use the gut. We're giving them either sub-Q or IV, okay? Most commonly IV in this case. All right, so Argatroban, Bivalirudin, these are the common agents that are used in clinical practice. Some agents come and go. Some are available in other countries more than others. In the chronic care situation, this is where our DOAC, right? Our direct oral anticoagulant options that are alternatives to warfarin therapies historically, and even also as another option compared to our factor Xa inhibitors. And that's your Dabigatran, which is administered by mouth. What I'd also like to show you is a table. Now, this table is available at thisiswhy.health. It's free for download. Feel free to use it for personal use, studying, share it with your friends, your colleagues. If those of you, do lectures or you precept students and residents, feel free to use it. That's why it was put together. Now, what I like about tables like this, not to be biased, is that it's important to understand drugs in the context of other drug classes, the big picture. What makes this unique class different from the other anticoagulants that we have available in our arsenal of choices? That's what drives us in the considerations of pharmacotherapy, picking the right drug for the right patient, the right clinical scenario. So in this table, and if those of you are listening on our podcast channels, I'll do my best to keep you oriented, but this is a table made up of multiple columns and rows, obviously, but the columns represent sort of the core anticoagulant subclasses. So we got warfarin first, unfractionated heparin, which is different from the low molecular weight heparins and even ultra low molecular weight heparin, fondaparinux. And then we have our direct Xa inhibitors, okay, and then our direct thrombin inhibitors. So we're at the end of this column. I'm not going to walk through every single one of these things, but what I've tried to do in each of the rows is give you some unique factor or characteristics. For example, the molecular weights a lot of times influence the way a drug can be administered, whether it binds to other things, some of the interpatient variability issues, And we see that with the direct thrombin inhibitors, they're actually fairly small molecules. This comes up when we get into the mechanism of action, because we need a drug sometimes, if we could, to penetrate an existing clot to prevent it from solidifying and continuing to grow. And so the size can be influenced in its pharmacodynamic effects. It can also influence the pharmacokinetic effects. And so when you look at the next row here on the route of administration, you see that these agents are predominantly given parenterally, but the Dabigatran is given by mouth. And that's what that D stands for. D means by mouth, PO. That's obviously we don't have enough space for every little detail, but I try to use these abbreviations to kind of just point you to that main effect. And then of course the main mechanism, and then things like titration, because we know that other drugs, especially like Warfarin, need very, tenuous, very difficult titrations to get patients to a therapeutic effect. And that's not necessary in the oral administered agents like the Dabigatran, but obviously with the IV, we may sometimes need to adjust that based on the monitoring parameters, which is the PTT and ACT that are used in that situation. When it comes to onset of action, when you're parenterally administered it's getting put in the central circulation, it's pretty quick and acute. Obviously, oral agents are going to take some time to absorb and develop into appropriate concentration. So for Dabigatran, it's at least 12 hours, where the other agents, it's really not applicable because we're administering them in the acute setting, which we'll talk about here in a second on indications and uses. I'm just trying to give you a snapshot of this class. And then when we think about, drug interactions and issues, it's really with Dabigatran being a P-glycoprotein major substrate, which is listed here. The other agents really are negligible, have no real main mechanisms of metabolism that really cause problems for us that we have to commonly think of. But the other big thing in this anticoagulation class, and one of the reasons why it's used, is it does not cause HIT. Okay? We do have an antidote that can bind to it. It's a monoclonal antibody, a humanized monoclonal antibody that can basically reverse it. And so that provides us with that option if we need it in an acute situation. Okay, now let's move into the next section, which is our common indications and uses in clinical practice. So one of the first things that we're going to see here again, and I recognize that some of you that are watching this may go, I don't practice in that environment. I don't do acute care. I'm a chronic care or ambulatory care, and vice versa. I understand that, but remember, our patients come in and out of the healthcare system, and sometimes we start drugs in one environment and we continue them in the other, and vice versa. Sometimes we have to stop one, transition somebody to one over another, depending on what situation is going on. And so I just want to make sure that we can kind of keep that big perspective and just understand the drug class and why within the drug class you pick one agent over another in a specific clinical scenario. So in our acute care scenarios where we're using those parenteral options, it's really in the context most commonly of HIT. Man, that's a classic board indication question drug class. This is the drug of choice if somebody has true heparin-induced thrombocytopenia. Remember, in that situation, patients are actually forming clots. They're thrombosing. Even though the platelets are dropping, they're dropping because they're being utilized to form these clots. And in forming those clots, they're forming microemboli that then infarct tissue. So we have got to give them an anticoagulant to stop that from happening. So you stop the heparin molecule that you're using, and you convert them over to a direct thrombin inhibitor. So that's classic, common uses for why we would administer this drug class. And the second is in the context of ST segment elevation, MI or STEMI, especially those who are going on to percutaneous coronary intervention, usually with the placement of a stent, obviously. Now, you may say, well, gosh, I've never seen that used. We don't do that. We just use heparin or low molecular weight heparin, and I get that. But some patients may have a history of HIT, and you can't do that. So you need to know what is the next best treatment. Here's the other thing. A lot of times the specialists, cardiologists and those people, interventionalists, They use what they trained under, what they feel comfortable with, maybe their bias and perspective on the clinical research. And all of that influences the geographic practices that occur. I know colleagues who use Bivalirudin in particular exclusively in these situations over other anticoagulants because of that very reason. There's nothing wrong with that. You just need to understand why it's sometimes different from one location to another. They're both correct in cases, and especially when you look at many of the guidelines. Now, from a chronic care standpoint, with Dabigatran, okay, this is most commonly used as a replacement for Warfarin in the prevention of cardioembolic stroke in patients with AFib. Now, the terminology of non-valvular AFib that's here, that has kind of fallen away, and the reason that's partially fallen away is due to the fact that the terminology, the evolution of the understanding of AFib has just changed, and there's different stages of that, which I'm not going to get into right now, but that doesn't really matter. The point of the matter is this patient is AFib, okay, and we're trying to prevent them from having a cardioembolic stroke, okay. Lastly, down here is the use in patients with VTEs, that's venous thromboembolic events. That includes things like DVT, a deep vein thrombosis, and also patients with a pulmonary embolism, PE. Okay, both of those are really important, whether for treatment, but also for prophylaxis in patients undergoing hip arthroplasties and replacements. Okay. Now, what I'd like to pivot to next is understanding the net benefit. Okay, I've already kind of dropped a few little hints about this already, but it's important that you recognize, why am I thinking about this drug class and what should I have in the back of my mind as I consider the utilization of it? Okay, first is that the direct thrombin inhibitors are essential. Okay, they are very helpful in managing thromboembolic disease states where heparin or other anticoagulants cannot be used or preferred. Now, the most common of that situation are patients who have HIT. Okay, now it's not just that, but think about we're going to talk in a minute about the mechanism of action. But you see the words up here where other anticoagulants cannot be used. Well, yes, HIT might be one, heparin, low molecular weight heparin, sure. But it's not just that. You are going to learn here, or if you watch those lectures that I do on the heparins, those drugs, including fondaparinux, require the presence of antithrombin in order for it to work. If you have antithrombin deficiency, right, then that's not going to be an option for you, right? You have to replace that or something like that, okay? And so that becomes very important to understanding the application of it. And that's where I was talking about at the beginning. This is where some of that confusion gets. What do you need in order for this drug to exert its effect? Well, you don't need anything else to bind to it, okay? That's important. Now, Dabigatran, you'll see here in a minute, is a prodrug. Okay, so it does have to be converted to its active form, but the value of it compared to the parenteral agents is that it's a DOAC. It's another alternative for oral anticoagulation that can be used in the outpatient, certainly in components of inpatient management of patients with certain medical conditions that we've talked about. Okay, now we're going to start to dive in the details of the pharmacology. Now, my goal here is not to overwhelm you, but remember, this is what I said at the beginning. When you understand mechanisms, and you're not just memorizing class names and just thinking, okay, I understand the mechanism, but when you really understand it, it starts to make sense of the reasons why we use it for indications and uses. It also makes sense of where we start to see side effects and other things, and as it relates to monitoring parameters and stuff like that. So what I'm showing you here is a diagram of the coagulation cascade in its normal function, right? So there's two sides of it. Again, for those of you joining us on our podcast channels, You obviously can't see this, but it's available at thisiswhy.health for you for free. The intrinsic pathway, kind of the internal process where you have factors 12, 11, 9, all of those eventually getting to 10A. Okay, now you'll see that 10A, if you don't remember some of the aspects of the coagulation cascade, is where the intrinsic and the extrinsic pathways merge. Okay, now the extrinsic pathway over here is typically utilized or seen or activated when we have some sort of vascular injury. Now it can be from trauma, it can be from surgery, it can also be from a vessel endothelial lining that has disrupted its function and has got a bunch of inflammatory response going on, and it starts to turn on and activate the coagulation cascade, but also activate platelets. So you see that platelets are over here. So the coagulation cascade, we most commonly don't think about it in the context of platelets being around. But the reality is, if you're going to form a thrombus or a clot, which is the final thing down here, all clots have a mixture of components of the coagulation cascade and platelets and some red blood cells mixed in there. The ratio of those, how much a clot is made up by one area or component over another, influences and drives the drug choices. In this case, when we think about patients with cardioembolic strokes from the pooling of blood in an atrium, that's more of a venous kind of clot scenario. DVT, PE, those are venous thromboembolic events. The venous side of a clot formation tends to lean more in the coagulation, clotting factors and fibrin. So anything that we can use to interrupt the coagulation cascade is going to work a little bit better, more effective at protecting against those venous generated clots. If we have an arterial injury, platelets tend to make up more of that clot. And so antiplatelet drugs make sense more in that scenario. So think about patients with atherosclerotic plaques, peripheral arterial disease, coronary artery atherosclerosis, the plaque ruptures, man, those platelets get activated. But guess what? The coagulation cascade also gets activated. And so if you stop and think about the management of conditions like acute coronary syndrome, okay, in the acute scenario, we are many times giving patients anticoagulants, heparin or low molecular weight heparins, or a direct thrombin inhibitor, right, parenterally administered. And we're commonly administered aspirin, right, or some other antiplatelet drug, like the P2Y12 receptor antagonists or inhibitors. Right? ADP inhibitors is another name for those. Those drugs are targeting different things, but we use them strategically in various scenarios. But we don't continue them that way forever. Right? Once we get control of the scenario, then we transition and titrate the meds down to the appropriate underlying cause. And so in this case, we're talking about anticoagulants focusing on indications that are more venous thromboembolic problems. And so the coagulation cascade is primarily that. And when we think about direct thrombin inhibitors, they directly target thrombin, okay, by itself. Nothing else needed. Doesn't need to bind to anything. It just binds to thrombin. Now thrombin, as you see here in the coagulation cascade, is really a very important contributor of what happens in the formation of a clot. There's a lot of other things that it does. I don't have time to get into all that. And again, I do a review on the overview of the coagulation cascade if you're interested in that, okay? But thrombin is a very common target of a lot of drugs, okay? And so in this case, it's factor 2A. That's the activated form of the clotting factor from prothrombin to thrombin, okay? That A is just the activated. And this becomes important because the clotting factors are made where? Well, they're generated and synthesized in the liver. But when they're made, they need to be functionally activated. They don't come out of the liver just instantaneously active. They must get activated through some process. And that's what this cascade is pointing to, the propagation and implementation of the coagulation cascade because you need it for some reason. Obviously, too much of anything is bad. Not enough is not good enough. So this is what we're targeting with direct thrombin inhibitors. We're directly targeting thrombin and taking it out. Okay, and that obviously then impacts the formation of fibrin monomers that form those cross links inside the clot that make it firm and solidified. Okay, and so that's the main mechanism that I wanted you guys to recognize. Now, I said, and I want to summarize here for you, direct thrombin inhibitors mechanistically do not require antithrombin. Remember, heparin, low molecular weight heparin, and fondaparinux do. Okay, it's very important. Next is these drugs do not bind to platelet factor 4. And that's one of the main reasons, when you understand the mechanism of pathology of HIT, that's one of the main reasons that the antigenicity is created. But these drugs don't bind to that. And so that's why they are drugs of choice in heparin-induced thrombocytopenia. Thrombin binding sites, it can bind to 1 or 2. That's what makes them what's called monovalent versus bivalent drugs. And then lastly, that size. As I mentioned earlier, their small size are able to get inside that clot, penetrate it. And as it penetrates that clot, it can help theoretically reduce the propagation and that solidification as the clot is thinner. It's kind of like a scab, right? It just sits there, gets harder and harder, and then a little bit takes longer to break down. This is a pharmacodynamic effect, again, that has a theoretical advantage that can, compared to other agents that are larger, okay? Now, clinically, at the end of the day, those endpoints, hard to discern, but pharmacodynamically interesting to talk about. Now, Dabigatran, from a pharmacology standpoint, is important because, as I said earlier, it is a prodrug. And a lot of times we make drugs into prodrugs to make it more, to be absorbed by mouth, improves the bioavailability. Maybe it's a side effect reason. We know that's the case for aspirin. That's the reason why they added the acetyl group to the salicylic acid to reduce the gastric irritation. That facilitates an improvement of tolerability, but it's still, at the end of the day, gets converted to salicylic acid in the body. Dabigatran gets converted to its active forms rather quickly, 2 hours after appropriate doses. And there are dosing requirements and adjustments in renal impairment, especially when you get less to a creatinine clearance less than 50, where the safety of the drugs have largely not been well studied. You do need to weigh the risk and benefit, especially when you have potentially other options available. Okay, wow, that was a pretty decent overview of some pharmacology that's legit, right? So I hope that it puts this class in a framework, but also gives you the subtle differences of why you pick one drug over another. Now we need to move over into the clinical knowledge. This is the pearls, the applications, the nuances, scenarios, patient-specific situations, things like that. Some of these I've already mentioned briefly. I'll add a little bit more to them. But the goal is to help you to take the core knowledge and see its application in the real clinical environment, okay? All right, so the first is obviously talking about patients needing something for HIT, okay, especially if they have renal impairment. There is a delicate balance here. One of the problems that we have in patients with HIT, as I mentioned before, is the thrombocytopenia is occurring because the platelets are being utilized and consumed to make clot. So we have got to give drug therapy that offers antithrombotic effect without increasing the risk of bleeding. Well, if drugs are renally eliminated, then it creates a little bit of a problem for us, right? Well, our heparins are renally eliminated, low molecular weight heparins are renally eliminated. So we start having to think about, well, what are our treatment options in those scenarios? So we do have to be very careful in the selection of the direct thrombin inhibitor that we're going to use. Okay, Fondaparinux is another one. Again, you got to be very careful with it. It's not saying we can't use it, just gotta weigh those risks and benefit. Argatroban is one of the preferred in renal insufficiency, although Bivalirudin can be used if you make, again, appropriate dose adjustments. So in the acute, nothing is easy, nothing is clean and perfect like we want it to be. And so these are, again, some of those clinical nuances that help to explain why we do what we do in various scenarios. Now, from a STEMI, okay, strategy, ST segment elevation MI, okay, Bivalirudin is mainly the drug that's primarily used in this situation. I've already kind of mentioned that with some of my friends and colleagues in other places in the country that preferentially use that in their protocols as they go to the cath lab. Okay, nothing wrong with that. It's an acceptable strategy for primary PCI intervention. Okay, many times these are going to be used, especially if you're not using it with a glycoprotein 2B3 receptor blocker. In those cases, patients are usually on a heparin or low molecular weight heparin. Okay, but this is where Bivalirudin can be helpful. However, when you look at some of the evidence that's out there, right, some of these strategies have suggested that they are interchangeable. Okay, but it's still being worked out. Maybe there's a little bit less bleeding observed in patients with Bival. And again, it has to do with your interpretation of the overall evidence and your real-world clinical experience. But again, some of these are, again, nuances that people talk about. All right, Argatroban, and you're now converting somebody over to a warfarin-based regimen, okay, because they need to get off of the parenterally administered drug. The problem with Argatroban is that it, just like warfarin, can prolong the INR. So then you get confused. Well, as I start the warfarin therapy, we know that it primarily impacts, right, the 2, 7, 9, and 10, which are part of that coagulation cascade. So that's going to cause the PT INR to go up. We use that as a benchmark for understanding when that patient gets to an INR of 2 to 3, that they have adequate anticoagulation to protect them from that clot without too much risk of bleeding, okay? So that transition to warfarin creates a problem because now you have two drugs influencing the INR, okay? So we typically keep these patients on, when you're converting them to warfarin, for 5 days with a stable INR of between 2 and 3, because we know at that point, 5 days usually gets them there, and they're now getting enough protection, even if they're subtherapeutic by the warfarin, theoretically, and we don't know yet because we've got another drug influencing it. That gives us a little bit enough time to protect the patient from these scenarios. Okay, now we're going to kind of move on to some dosing and drug administration issues or considerations, specifically with Dabigatran. The other agents are parenterally administered, so kind of talked about that. But dyspepsia is a big problem with Dabigatran. In fact, it can be enough where patients don't want to take it, right? So there's options. You can consider use of taking it with meals. You can look at using PPIs, which I'll mention here, but we can't break or open the capsules because the absorption is compromised fairly significantly, and this can lead to adverse events, okay? So we also recommend you keep it in the original storage container to protect it from moisture. Again, we don't want it to get converted rapidly or to disintegrate. We want to facilitate maximum absorption in these patients without increases in major side effects. So many patients who cannot tolerate this may require some alternative option in the interim, right? Or you can consider adding on things like proton pump inhibitors to reduce some of the acid that's causing the dyspepsia in particular. But if you do that, you need to separate the Dabigatran by at least 2 hours if possible. Now, no real phase 1 or phase 2 metabolic pathways, okay? So phase 1 being your cytochrome P450, phase 2 being your sort of conjugative pathways to make the drugs more water soluble for elimination. So there's not a lot of drug interactions through those pathways. However, Dabigatran is a major substrate. That means it requires the use of P-glycoprotein for its elimination from the body or movement in and out of cells. P-glycoprotein is a major efflux cell membrane transporter, and so when it's highly dependent on that transporter, there are a lot of drugs that inhibit it. And in fact, many drugs that seem to modulate the activity of cytochrome P450-3A4 will many times interact with P-glycoprotein. We see that with the protease inhibitors for HIV. That's very classic. Some of our rate controlling drugs in cardiology are known to do that. So just be very careful that it's not a cytochrome P450 thing. It is a P-glycoprotein thing with Dabigatran, not the other agents. So the parenteral agents, really, remember there's no metabolic pathways. It is really Dabigatran that we're worried about. Going back to our chart where I was talking about monitoring, right? So you've implemented these drugs, you're using them, what do you need to monitor for? Well, from an anticoagulation perspective, the PTT, PT, INR, the activated clotting times help you to understand a little bit of what's going on with the coagulation cascade. The intrinsic pathways tend to be a little bit more of that PTT. Extrinsic pathways tend to be a little bit more of the PT. There's blurred lines, obviously, because they converge at factor 10. Now, Argatroban and Bivalirudin use the aPTT of 1.5 to 2 times, okay, the upper limit of the normal from the baseline. That patient's baseline is kind of the goal that you are pursuing, okay? Now, Dabigatran, which is administered by mouth, doesn't have routine monitoring. So like when you consider Warfarin, where you have to get the PT-INRs checked, we don't have that, right? Same thing with our other DOACs, the factor 10A inhibitors. We don't have to do that. So it doesn't reliably affect the PTT, so it doesn't help us a lot. We'll still check them in acute situation where patients are bleeding, but it really doesn't help us fully explain everything. Now, when we think about monitoring of other labs, okay, before initiation of therapy, but then also periodically thereafter, why would you monitor? I mean, this should make sense. Why would you order a CBC, a complete blood count? Well, remember, you're going to get the white blood cells, the hemoglobin, hematocrit, right? You'll get the RBC indices and things like that if you do the differentials. But what are we worried about? Bleeding, right? I mean, we're making people at increased risk of bleeding. And so your first obvious one outside of seeing actual blood is that you will see interval changes in their hemoglobin and hematocrits. They'll start dropping. Now, we're not monitoring a CBC for platelets, which is what we would do with heparin molecules or low molecular weight heparin agents because of the risk of hit, right? So we want that baseline so that if they start dropping precipitously and when the patient has clinical, manifestations of, multi-infarct going on throughout the body, then it puts things together, but you got to have that baseline. So in this case, we want to look for trends of bleeding. And this is really important, especially in our aging, older population if we're using it and chronically as an outpatient, especially with the oral agent. Serum creatinine. Again, that goes back to renal dose adjustments, especially those who have really an impairment of their kidney function. And again, as we age, the population age, our GFR tends to go down. So we want to weigh that in the risk of bleeding in the context of these. What about these liver enzymes and function tests? Why would we check those? Well, remember, liver function tests are looking at the functionality of that liver. Well, one of the functions of the liver is to make clotting factors. I alluded that earlier in the mechanism. Remember, we make the clotting factors. They have to then get out into circulation and get activated. But you got to have one made in order to get activated. And so why we would look at these is look for trends where the liver is either being damaged from something, hep C, alcohol, some other cause for cirrhosis, or hepatitis. And it's compromising not only metabolic pathways for drugs, but it's affecting the function of it. And that's why we check the PT and PTT can be influenced in part because of the liver, because of those clotting factors that are present. And so the enzymes help us to understand that cells are breaking down or are being damaged, and then the liver function tests do exactly what they say, to helping us to assess the function. So we do these things, we keep them in the back of our mind, but that's why we're ordering certain tests in certain situations and in not certain drugs. So Dabigatran doesn't need the coags necessarily, unless you're worried about the liver starting to fail. Okay guys, let's now move into kind of the summary and wrapping it up. Again, this table here that's available for you at thisiswhy.health is designed to help you summarize the key points and compare it from one class to another. Okay? So in this class, our direct thrombin inhibitors, we have Argatroban and Bivalirudin, we have Dabigatran, that's our oral class agent for that make up one of our DOAC options. Okay? We have the Argatroban, Bival, those are your parenterally administered, largely reserved for acute situations like HIT, STEMI, whereas Dabigatran for that DVT, PE, patients with AFib, trying to protect them from cardioembolic strokes, okay? Next is looking at mechanisms. So the mechanism of action does not require the use of antithrombin, okay? It doesn't bind to platelet factor 4, so it's not going to cause HIT. There are some issues, again, with drug interactions, mainly with Dabigatran, P-glycoprotein, okay? So counseling points are looking at things like, stuff like, risk of bleeding. Also looking at risk for drug interactions. As new drugs get added to people's regimen, they need to be aware they may need to consult with you, okay? So I hope that you found this to be helpful and useful to your everyday clinical practice. At the same time, your knowledge base, especially if those of you that are learning this for the first time, it's important to understand the why. Don't please, guys, you have to memorize some things. You have to memorize brand names, generic names, the drug class, and what's in them. Sure, I get it. But man, it starts to make more sense to you. You don't have to think about these things and try to recall them from your memory when you understand why. So please, if you have not already subscribed to my YouTube channel, please take a moment to do that. Also, give us a like. We really appreciate that. It helps us to keep continuing to provide this type of content for you. So I'm Dr. Busti. Thanks so much again for joining us. Thanks for all that you're doing and investing in your knowledge base. We'll see you next time.